let's have a closer look at the inspection in the lumbar spine. Well, a first thing which is interesting to pay attention to is during the history phase, when you're asking a lot of questions to the patient, look at his posture. How is he sitting? Sitting in a slouched position, sitting in an upright position, is he sitting still, is he moving a lot, what's the expression on his or her face? That can already tell you quite some interesting feedback. Also, when the patient is undressing, it's interesting to have a look how he does that. I don't like very much those separate spaces behind the curtain where the patient is undressing and dressing, because in that case I could miss some interesting information. And that's a pity. Also, later on, after the treatment, when we focus on prophylactic, preventive strategy, then it's interesting to see how the patient is dealing with putting on his clothes again. The patient is standing in front of you, and mostly I put the patient in front of a mirror, and then it's interesting to see if he's able to have equal weight bearing on both feet. For instance, a patient with an acute sciatica, a big disc protrusion, lateral disc protrusion with pressure against the nerve root, acute sciatica, he very often also shows a very beautiful lateral deviation. And he can't put his full weight on both feet at the same time. He puts more weight on one foot and less on the other one. Sometimes even it's impossible to put the heel on the floor because it hurts too much in the leg. Another situation where you could see something similar, this is a patient who suffers from a very acute sacroiliac arthritis, but this is rather rare. But talking about deviation, well, deviation could be very interesting. For instance, a patient who stands in front of you with a flexion deviation coming from the lumbar spine. Not from the hip. If you see a flexion deviation coming from the hip, then this is rather a yellow flag. But mostly you see a flexion deviation coming from the spine, and in that case the chance is pretty big that the patient has a big, nice lumbar internal derangement. Sometimes they show a lateral deviation. I'm talking about a pure lateral deviation, not about a lateral deviation in combination with rotation, because that would be a scoliosis. No, we're talking about a pure lateral deviation, also in the spine. Well, this is also typical for, in the majority of the cases, for a bigger lumbar internal derangement. Mostly, of course, they still have a lot of pain, but occasionally you see a patient who still has a lateral deviation, but with less or even without pain. In that case, we could do a series of anti-deviation treatment techniques, which are quite useful. Another thing you could notice when the patient is standing is we see some wasting, for instance, an atrophy of his calf muscles. Perhaps there's a motor deficit. A patient suffering from a sciatica S1, S2, and when there is too much pressure on nerve root, could result in a motor deficit. Anyhow, we have to check that in our motor examination during the functional examination procedure. Actually, we don't palpate a lot in the lumbar spine for the simple reason that palpation, and certainly palpation for segmental mobility and palpation for tenderness, in the absolute majority of the cases, this is highly irrelevant. In fact, we do one palpation in standing, we palpate along the spinous processes, and we could find two things. Perhaps we find an angular kyphosis, and let's imagine the patient is younger and he has a lot of central back pain, not a lot of radiation of pain, and there was a trauma in the story. And then you find an angular kyphosis. Well, in that case, send the patient immediately for medical imaging, because that could be related to a fracture. If you see the same angular kyphosis in elderly patients, then there was no trauma in the story, then this could have a rather innocent, well, more or less innocent reason, more specifically severe local degeneration. But anyhow, if they have local pain, and if they have a lot of pain and they don't have radiation of pain, then perhaps we better check biomedical imaging. But we could also find a shelf on palpation, and a shelf is related to a spondylolisthesis, which of course you can see on medical imaging. But let's not jump to conclusions too fast. You could find a shelf, you could see a spondylolisthesis, but that doesn't necessarily mean that the symptoms of the patient are related to that spondylolisthesis at this moment. All the puzzle pieces have to fit. And one of the important puzzle pieces is, as you know, the history. And what is a typical history of the spondylolisthesis patient? Well, he tells us that he has more symptoms during walking and standing, and the symptoms disappear in sitting and lying. So pain on walking and standing, which disappears on sitting and lying. That's quite a different story than in comparison to most of the patients with an internal derangement. They say exactly the opposite. So look for all the puzzle pieces. And in case you would notice something else which in your opinion might be significant, of course, then here you still have some space to share those remarks.